Hello and happy Teach Me Tuesday. My name is Lisa Houston and I am a clinical nurse educator specifically for the NICU. Thank you for joining me in this month of August where we are kind of redoing, updating things that we did last August as part of our 1-year anniversary of Houston We Have a, which is my Instagram handle and my TikTok handle, and here of course on YouTube. So be sure to be following me on all of those pages. Today, we are going to dive into a topic we previously discussed, which was NAS, which is now more known as NOWS or NOWS. So let's dive in. Neonatal abstinence syndrome is now more commonly known as neonatal opioid withdrawal syndrome, or NOWS. I'm going to call it NOWS during this education time together, and it's just kind of an easier than saying the whole mouthful. But it, to me, was an important update because really this whole idea of what we're doing with the non-pharm and pharmacological treatment of babies that have been exposed to substances really is about opioid withdrawal. We are going to talk about how other medications and drugs contribute to the withdrawal that the baby's going through, but really it is about opioids. So we know that this withdrawal comes from that sudden discontinuation. So it's like you've had this supply and we suddenly don't. And we know how important the placenta is, right? We've talked about this so many times. In fact, I feel like we should just do a bonus placenta because I love talking about it so much. But the placenta's job is to supply the baby with the things from mom. So if mom is taking things that she shouldn't be taking or has to take due to a medical condition, the baby is going to be seeing that, and then all of a sudden they are not. It's very similar with IDM babies who have maybe been getting insulin from their mom, like insulin doses and all of that, and then they don't. It all just kind of is this sudden discontinuation of something that they were getting. So these symptoms that they may experience include irritability, tremors, all those things that you can think, right? But it can escalate into seizures. So the management really is the supportive care. And what the evidence is now telling us, which we already probably knew, but with Eat, Sleep, Console, which we're going to talk about, we really know that we have to be doing treatment, right? We have to have education and intervention for the whole family. Thinking that we can just treat the baby really isn't going to get us that far. We have to be able to make sure that all of our families, whoever the caregiver is going to be for the baby, hopefully the mom or the dad, if not the foster family, the adoptive family, the other caregivers in the family that are going to be helping, really can get involved in this early identification and treatment. That is going to cut down on our complications. So let's talk about what the baby's exposed to. When we talk about opioids, right, it's everything you think of: oxycodone, Vicodin, morphine, codeine. This list is not, what's the word I want? It's not inclusive of every possible thing. This is just a list of probably the most common things we see, including methadone and Subutex. We know that both methadone and Subutex are given to people in recovery to help with their recovery. It is a prescribed medication, and taken as a prescribed medication in the dose it is prescribed in will still cause withdrawal symptoms. So we think to ourselves, oh, can't the moms just go off of that while they're pregnant? And really you can't. And the benefit of them being on it and being on a stable dose far outweighs any consequence or withdrawal, or not withdrawal, any negative to them being on it. So we want them to remain on it and try not to discontinue that during their pregnancy. Symptoms can occur immediately or after. It can cause crying, feeding, hypertonia, all these things that we're going to be talking about throughout this entire slide deck. Sometimes we don't see those effects right away, and we're going to talk about things that affect that. But it's just super important to note that there's no one way to say, oh, this mom did this much or took this dose of methadone or was shooting heroin every single day, the baby's going to have this much withdrawal. It doesn't work like that. It's not a continuum based on exact exposure. So keep that in mind. Polypharmacy contributes to these withdrawal symptoms. So SSRIs such as Zoloft or Celexa, can cause jitteriness, respiratory distress. Usually we're going to see that kind of stuff in that first immediate period following delivery. What's important to know, though, is that that can contribute if additionally mom was on methadone or oxycodone or Vicodin, whatever it is. The baby will now have a double withdrawal. So benzos, such as Ativan, those symptoms can take longer because of their half-life into the baby. And then we can also see like, okay, we feel like we had this managed and now we're having this other thing happen where we're having another withdrawal. Another drug that you need to consider is nicotine. Nicotine has a very big effect on the baby, and in fact, there are some studies coming out about what the nicotine is going into the breast milk, and if the baby's not getting the breast milk all the time, they can have changes in their behavior, such as jitteriness, crying. I've seen babies that when they're on their parent who has smoked cigarettes, they might be calmer, and then when they're taken away, it's like they're getting it and absorbed through them. I don't have the evidence about that. It's just my own personal experience. But nicotine is a huge contributor to what is going on with the baby's symptoms. So let's talk about the symptoms. The severity of this is going to depend on the amount and the purity of the substance. So we saw in that last slide, which I didn't read every word to you, but fentanyl can be used in this pure thing that we get from a pharmacy. Like, I hope not. I know that I say that and it's probably not true, but I'm sure it's happening somewhere. Or it's mixed into a street drug. So the street drugs, I don't know enough about them because I don't do them, and that's not my area of specialty, but they vary in their purity. And they have things mixed in with them. And so really depending on how much of the actual substances the babies are getting exposed to is in the drugs is going to affect it. This polypharmacy is, again, are we on multiple different opioids? Is the mom getting a dose of methadone but still actively using? Are we abusing methadone and getting it from somewhere that maybe we shouldn't be getting it? How long has the mom been using? When was the last use? What is the mom's metabolism? Her metabolism and the baby's metabolism greatly affect how soon withdrawal symptoms happen and how severe they are. So when you take all of that into consideration, you can see how the withdrawal and the symptoms really depend on the baby. So if we look at their different symptoms, this is what we're all pretty used to seeing, those neurological symptoms, the irritability, excessive crying, tremors, jitteriness, sleep disturbances, gastrointestinal, these babies that have the diarrhea that end up with the skin breakdown. It can lead to dehydration from all of that diarrhea. The autonomic nervous system, the sweating, the fever, the yawning, mottling, and then of course we have some respiratory symptoms. Tachypnea, you will see nasal flaring on some old scoring systems, so that is there as well. But now what evidence is telling us, and this is why this is an updated slideshow, is really this idea of what Eat, Sleep, Console has taught us about the symptoms. So a lot of places we're using kind of a subjective system where you're looking at it and it's like, did the baby sneeze more than 4 times? Okay, well, is that like more than 4 times since the last time I scored you? Was it 4 times just since I've been standing in the room? Did the infant sleep 1 hour? Okay, well, was it 1 hour continuously? Did I have to hold the baby? How much intervention was required to get the baby to sleep that 1 hour? So what the Eat, Sleep, Console method has done is that it's gone in, it's a method that's emerged, it's this approach to saying, how is the baby's functioning? So it's almost like when you hear that babies get occupational therapy and you're like, what is their occupation, right? Their occupation is to be a baby. And so what babies are supposed to do is to eat, sleep, and poop. Eat, sleep, and be calm, right? And so that's what this Eat, Sleep, Console method really is looking at, is can the baby function? So when you think of it almost in this OT kind of way, it's like, do they have the tools and resources they need to be able to effectively go about their day, right? Our little baby day. So you end up asking yourself 3 questions with a caveat of another thing that I will tell you here. But the first question is, can the baby eat greater than 1 ounce or breastfeed well per feed? And that means pretty much, can they take that ounce within that, typically in the NICU we say 30 minutes. Are they able to get on to latch on either to the breast or to the bottle to successfully suck, swallow, and breathe, where they're not spilling it out, having to come off and come on, that they can't latch onto the bottle, that is even taking interventions to get them in there. So can they do that? Question number 1. Question 2 is, can the infant sleep greater than 1 hour? And every unit is going to kind of have a different idea of what that means. Is can they sleep in their bed? Can they sleep in the arms of a care partner or somebody that's in there helping them, or their parents or a nurse? And you have to define that for your unit. The evidence really is about, can they sleep for 1 hour in their bed? So that's pretty much the length of time that it's considered for a newborn to sleep alone in a bed without an intervention is a function of a newborn baby. So remember, if we go back to occupational therapy, that's what our functioning is. Can the baby function? We expect them to function like a newborn. It is important to remember, if you have a baby or don't, or if you ever babysat, newborns are not meant to sleep for 4 to 6 hours at a time. It's just not a thing. Pretty much if your newborn sleeps for 3 hours, I would say you're doing something magical. That first month, they often are cluster feeding. They'll wake up every hour. So that is where this evidence comes from, is can they sleep greater than 1 hour? And the third question is, can the infant be consoled within 10 minutes? So you're not saying, okay, I'm just going to give you the pacifier and you're going to do okay. You're saying, I'm going to give you 10 minutes to kind of let me do some interventions, some non-pharmacological interventions, and can we get you to a place where you can be consoled? Now, you're going to have another question about how much effort did it take to get the infant consoled. And I always think of this as kind of like, what is my body doing? Am I having to kind of bounce and pat and shh, and we have white noise on, and the room's cold, and I'm giving you the pacifier, and we're in a rocking chair, or I've done this and then I've handed you off to your mom, or I've done this and I've handed you off to a volunteer, whatever it is. If we're having to do multiple interventions to the point of this like exhaustive situation, we have to think about, is that sustainable for anyone, but especially for the parent? Eat, Sleep, Console really stresses this idea that we need our families to be in here to be able to do this. This is all around family-centered care. If the family is able to be there at the bedside, right, if they are in a healthy enough place for themselves, whether that is the biological parents, the foster parents, the adoptive parents, whoever it might be, we want them to be the main person in there really doing this and learning how to console their baby. Because at the end of the day, it's key for us as bedside nurses to remember that the parents are going to be the ones taking the baby home, not us. So if it requires constantly walking and kind of patting or doing the 5 S's, right? Shushing, swaddling, sucking, swaying, and the 5th S, which is of course not going to come to me. We have to really think about how sustainable is that for our families, because they also will need to be able to rest. If you ask these questions and you answer no, it tells you to start with non-pharmacological interventions and then escalate with pharmacological interventions as needed. So let's talk about those non-pharms, right? It's essential for the parents. I can't stress enough this idea that we need our parents to be present at the bedside. What Eat, Sleep, Console has also done is really empowered babies to be able to stay more in a mom-baby type of unit, postpartum unit, whatever you call it in your facility, instead of having to go to the NICU. That if we can teach our parents this, that often they won't need to come to the NICU for morphine doses or methadone, whatever your unit is using, which we'll look at a little bit on the next slide. But can we have dim lighting, low temperatures, calming voices, calming sounds like whether that white noise or that shushing noise? For our babies with diarrhea, are we using skin barrier? Are we doing low volume and frequent fleeds? Are we putting them in the soft clothing? And then the parents, are we swaddling and having that firm touch, using non-nutritive sucking, giving the pacifier? Having a quick response to the baby. Anytime a baby with NOWS is escalated, it is tricky to kind of bring them back down into a place of contentment and consoling. So if we can get into those interventions early, in many NICUs, they try to keep these on 2 baby assignments so that you are not pulled in so many directions. And if you don't have a family present, that's going to be even more important because we can't be in there all the time. We have other babies to consider, whether they are in our patient care assignment or throughout the unit. It is also important that we remember that our families as caregivers, they are the primary caregivers, also need breaks. It is one thing that's been hard for me over my career is to hear people say like, oh, they went back to a room, or they asked for a courtesy room so they could sleep for a couple hours, or they slept through one of the cares last night. And I'm like, well, they needed a break. They did it for 6 hours straight. They need a break. This is a great time for them to ask for a break in a safe environment where we can help them. So encourage your families to do that. Make sure that we are being present with them, letting them know that we support their decisions, and that if they need to take a break, that they should, that we can help them to get to that break. Because if these non-pharmacological treatments aren't working, we are going to escalate to pharmacological treatments. And I am going to be honest, the 2 that I have primarily used, I went through and re-updated this and made sure I had the most evidence out there. But really the ones I've seen the most is morphine and clonidine. And I have worked one place where there was some phenobarbital when there was a serious polypharmacy situation going on. But primarily I think we all use morphine. And what I've seen with some Eat, Sleep, Console protocols, one that I've used and a couple I've saw in the evidence, is that some places are starting with flat doses. And that is to keep babies in kind of this mom-baby postpartum labor and delivery experience where you can give them a flat dose where we aren't worried about apnea. The baby doesn't need to be monitored all the time. Sometimes a baby can get just one flat dose when they're at the peak of their withdrawal, and that's all they need, and then they avoid this NICU stay, especially if you're in a NICU that doesn't have single patient rooms, that doesn't have somewhere for parents to stay. Methadone can be used to treat NOWS. That is something that is coming out of the evidence even more, even for what you can see is the same reason that the parents are using it. The other meds, I don't know as well. I'm going to be honest with you. I come to you as transparent and authentic as I can be in what I have used in my practice. I've definitely used clonidine, and I've seen babies go home on clonidine as a medication that is safe for discharge. It can have effects on your blood pressure, so it is really important that these babies' blood pressure is monitored closely if they are going to go home on it. And that's what I've seen. But this really is this, when you think about what withdrawal is, right? We think about this idea that we're giving them morphine because they're in pain, when really we're giving them morphine to get to those opioid receptors in the central nervous system. And say how I picture it is when I picture a neuron, right? A neuron always looks like this big, where's my camera? Like reaching out thing. And these neurons are used to having been receiving these opioids. And so all of a sudden they're like, where to go, where to go, where to go, where to go? I need it, I need it, I need it, I need it, I need it. And all morphine's doing is coming and saying, okay, right, let's quiet down. It binds to and activates these receptors in the central nervous system so that the baby can slowly say, we don't need you, we don't need you, we don't need you. And so that's what morphine's doing. It's not the same as like I break my leg and I need to get up there because this is a pain thing. So this is also why you don't see sucrose on this list, right? Sucrose is used to treat painful procedures, and withdrawal in and of itself is not a painful thing. They can be having painful procedures such as blood draws and G-tube insertions, whatever it might be, which they would need sucrose for. But giving a baby sucrose over and over again just to get them to suck on a pacifier is probably defeating the purpose. They probably need something more, whether it's eat, sleeping, or consoling, or something such as a pharmacological treatment. So I just want you to think about that when you're thinking about morphine or methadone or any of these things, that really don't just think that the baby's in pain. It's about the central nervous system. Super important, because clonidine is also about the nervous system, right? Clonidine is often used just to treat hypertension, which I learned as a NICU nurse. Did not know that. Maybe I did. in nursing school. Who knows? But I don't barely remember nursing school. But for these babies, we're using it for their autonomic nervous system. So this is an exhaustive list. Pause, read through it. It's got a lot of good information there. I'm not going to read it to you, but you can pause me anytime. The joy of YouTube. When we talk about long-term outcomes, these babies really are at risk mostly for developmental delays, behavioral issues. We know there was a huge rise as the opioid epidemic started, really in babies that were born drug exposed. They had an increase in ADHD, behavioral interventions, problems at school. I was reading this huge article, this was probably 5 years ago, so at this point it might be outdated, but it was talking about these places that first started treating it. We saw it kind of in the Appalachian Mountain area, in Kentucky, Tennessee. Tennessee was one of the first hospitals that had a specific, well, at the time they called it NAS unit, a NOWS unit. But what they saw is about 5 to 7 years after they saw a rise in the babies born with it, they saw a rise in the diagnoses of ADHD, hyperactivity, impulsivity. So it's important to kind of track those long-term things. This is greatly influenced by their environmental factors, their caregiving, their socioeconomic status, their access to healthcare, and their early intervention. It's just as important that these babies are getting long-term follow-up as it is for an extremely low birth weight baby. Because of these ways that we can intervene early and often for them, it really is so important. And often I think we kind of forget about that idea, and we forget that we need to get them on that follow-up clinic list or make sure that they have an appointment scheduled. And if a baby goes into foster care, how can we make sure that the foster families are also connected with these appointments? So we've had this idea like, hey, parents, we need you at the bedside. You are the crucial connection to make sure that Eat, Sleep, Console or any management of your baby's symptoms has gone well. So we can't just be like, hey, it's so important for you here. We need to be like, let's get your baby skin to skin. Let's get them breastfeeding if that's acceptable for what your baby and mom are going through. How can we help you comfort them? What symptoms can you expect? Teaching them this irritability, this crying, this poor feeding is all part of the withdrawal, and we expect that it's going to get better. It might peak and then the baby will come down, but what our expectation is that what your baby's experiencing right now is a normal outcome and it will get better. Treatment options. The non-farm and the farm, what we just talked about, what the severity is, what they can expect, when they could expect that we would intervene. If we're doing Eat, Sleep, Console, like, hey, if we're saying no, they can't eat, no, they can't sleep, no, they can't console, we're going to probably be starting medications sooner. And then how long could they expect to stay in the hospital? If they have admitted to a NICU and they're on doses of morphine, kind of what is that escalation and de-escalation of the medications is going to be key to their understanding. So what we know about NOWS is that we can't undo it, right? There's a lot of things that we think, okay, we can prevent preterm birth if we put a cerclage in. We can have some issues with chronic lung disease if we give steroids. We can give a mom with GBS positive swab antibiotics prior to delivery to lessen it. With NOWS, it is just an expected outcome of a baby that is exposed to antenatal drug use, whether that is medications mom's been prescribed. We had a baby once, I remember this so specifically, that when the mom was about 20 weeks pregnant, she was diagnosed with cancer. And it was cancer in her bones, and she was in severe pain. They ended up delivering the baby at about 27 weeks, which again isn't exactly babies we use for Eat, Sleep, Console, but this idea that we do prescribe pain medications. Moms have been in car accidents. They've had things happen to them where we've had to prescribe them this. So it's not just these street illicit drugs, so it's important to keep those things in mind. But Eat, Sleep, Console really is this family-centered approach. So whatever the definition of family is for that baby, who can we bring in to teach them what's going to happen here? It's also so important is the baby is going to go home probably still experiencing some symptoms. They don't go home completely symptom-free. They go home with managed symptoms that are improving. So we want to make sure that any caregiver that's taking them home knows what the non-pharmacological interventions are for these babies, including skin-to-skin contact, managing their symptoms, comforting them, non-nutritive sucking, etc. So thank you for joining me on this Teach Me Tuesday for our revamp of NOWS. If you have any questions, please comment it or message me. Be sure you're following me on Instagram and TikTok, and here subscribing so you can see new videos every Tuesday. Have a great week.